Hello, my name is Quanisha Simmons, and I'm a BSN student here at Florida State College of Jacksonville. And I'm going to be talking to you guys about the effects of 12-hour shifts and the effect that it have on medical errors. The PICO question related to our topic is, in a general healthcare setting, how does using evidence-based practice for staffing and scheduling compared to customary nurse staffing practices affect the number of medical errors over a 30-day period? And when we talk about evidence-based practice, there are three components when it relates to evidence-based practice. You have patient values, clinical expertise, and best evidence research. And we combine all of those things to get evidence-based practice. Throughout our talk today, we're going to talk about some different things. We're going to talk about the medical errors, the research evidence that is associated with it, and how to identify the effects of working extended hours and the effect that it has on medical errors. We will also be reviewing some of the outcomes, the recommendation guidelines, interventions for the nursing supervisor as well as the practicing nurse. Some of the nursing data. With the nursing data, we all know that according to the American Nurses Association, nurses are the largest group of healthcare providers. And there are currently over 3.1 million active practicing nurses. And of that, even though we have that many nurses, there's still actually a nursing shortage. And the 12-hour shift policy was kind of initiated in order to bring value to the nurses as they work with their patients, allow nurses flexibility, as well as allowing them the opportunity to bond with their patients and have that nurse-to-patient relationship. But the research findings tells us that extended hours is not best for the patient. It also has a negative effect on the nurse as well. So you always want to be aware of the safe practices by reviewing evidence-based practice. And there are some errors or mortality review as it relates to working those extended hours. And according to the Washington State Nurses Association, there's a 31% chance that a patient will die post-surgery related to a nurse that is working extended hours. We also learned through our research that you are 3 times more likely to make an error. Aiken, which we'll talk about a little bit later, also did a lot of research, and in some of her research it was identified that related to that, you can have 7% increased failure to rescue and a 30% chance of dying within 30 days of your admission. And this is all related to working extended hours and fatigue of the nurses. So there's some guidelines that we're going to review in relation to this. So also we're going to have a test afterwards, so if you want to take some notes throughout these slides, you can as well. Medical errors classifications. According to one of the systemic reviews that I researched on Clendon and Gibbons, it's talked about 8 categories of medical errors. Lack of attentiveness is just basically misreading an IV or something like that, just not paying attention to what you're doing. Lack of agency concern or failure to advocate. When you're working with individuals that are nonverbal, if you fail to advocate for that patient, that can also be considered a medical error. Inappropriate judgment. It's just poor assessment skills. So you want to make sure that you're paying attention to your patient, because some of the things that are going on with them can identify whether or not they're in pain or something else is going on. So you want to be good with your assessment skills. Medication error, giving that medication via the wrong route, the wrong person, the wrong time. Medication error is a really big one that we'll discuss a little bit more as well. Missed or mistaken provider orders. Sometimes you have to read through the reports, and you want to make sure that you're getting all of the information as it relates to the order. And if you don't have proper information or enough information, you always want to clarify those orders. Lack of intervention on the patient behalf. When we talk about lack of interventions, that's like if you get an abnormal lab value that you see and it relates to something else, you want to make sure you're reporting those. Now in the hospital, the doctors have access to all of this, but when you're working in a facility that's still on paper, as the facility where I am, you want to definitely make sure that you're reporting these lab values to the doctor, to the provider, because they cannot always see that information. Lack of documentation errors. Documentation errors, you all know in nursing, if you don't document, it wasn't done. So you want to make sure you have thorough documentation. And lack of prevention. This relates to prevention of falls. So if you fail to protect this person from falls, you are in error. Infection control. If you do anything to cross-contaminate that individual, you are in error related to infection control. So these are just some of the medical error classifications according to Clendon and Gibbons. Some additional research in a study by Duffield, which was an observational cross-sectional study, identified some other things. In his study, he combined some other skill mixes, some other classifications in that. The skill mix, meaning whether you have BSN nurses working together along with regular nurses, or LPNs working with RNs. So they combined the skill mix. The job satisfaction was also combined in that. Workload, the work environment, and all of those were combined to get the data to work on the patient outcomes. And it was identified that only 67% of nurses were actually satisfied with their job. And some of the patient outcomes that were talked about was falls. We have medication error and time-based errors. So medication errors had two different classifications, with medication errors coming in at 15.8% and the other time-based errors at 28.5%. So with that, the results suggest that there's a big improvement factor that needs to be made when it comes to staffing with the workload of the nurses to lead for improvements on the patient's outcome. Additional research by Bay was a different study. In this study, it was a random sample study that was conducted by Bay, and in her study, she utilized the survey reports of 173 different nurses coming from North Carolina and West Virginia. And in this study, it was identified that nurses' injury as well as adverse patient outcomes were taking place, and that adverse patient outcomes were being done at a higher rate. So not only is working extended hours negatively affecting the nurses, it is also affecting the patient. Needle sticks were high, at 13%. You had sprains, and the highest for the nurses was verbal abuse. When you are tired, sometimes you may get loud with your patients, and that's considered verbal abuse. You have to treat them like they are human, like they are great patients. So you don't want to verbally abuse your patients. Some of the other medication errors, the highest one on the patient outcome was medication errors. So again, medication errors is popping up a lot when we talk about working extended hours. So some of the recommendations that were given according to the Agency for Healthcare Research Quality is about medication risk and reduction strategies. Since we talked a lot about medication errors, in your student handout, if you pull that out, we're going to go over a policy in regards to medication errors. It's just some ways that we can prevent medication errors. And with us all being practicing nurses, we pass meds every day, but just a basic review of the policies will be a good idea for you to kind of just refresh yourself up on your company's policies, not specifically this one. This is a very general-based guideline as to how you should properly do medication administration. The first thing you want to do is know that medications are to be prepared and administered by a licensed nurse, and that's state law, or authorized personnel. You want to make sure that you're following the guidelines of the physician. You want to follow the order. So again, like we stated earlier, if the order is not clear, you want to make sure you have clarification on that. So if the dosage that the doctor has provided you is higher than what is expected of that patient versus their size, their age, and it doesn't look right to you, always call the doctor to get clarification on that. And the 8 rights of administering medication is the right person, the right drug, the right dose, the right time, the right route, the right method, the right documentation, and always the person has the right to refuse. So if they refuse their medication, we just want to make sure we document it. Medication should be administered either 1 hour before or 1 hour after the scheduled time, except in the instance where you have medications that are to be given prior to meals or after meals. You have to give those at the stated time. The right form. The medication should always be administered in the right form. If it's a crutch medication or if it's a liquid, you want to make sure that you're doing it in the correct format. The MAR. The MAR is something that you should always look at. In the hospitals, there are electronic systems and the medications are there. They pop up and you scan the medication. But when you're in a facility that does not have that luxury, you have to read that MAR. You have to make sure that the medication is being dispensed at the right time and it has the consumer's name on there, the right strength of the medication. All the information should be correct as it relates to the MAR and the pill pack that you're probably going to be popping out of. Consumer identification. You always want to use 2 different identifiers when you're giving meds. Don't just always go by one identifier. You call the person by the name and then they might just answer. You might not know that they may be not coherent at the time and they're just answering. So you definitely want to use at least 2 different identifiers when you're passing your meds. And always do the proper procedures. Wash your hands, wash your hands, wash your hands before, after, touching meds. Infection control plays a good part in that. And documentation. On the MAR, you always want to make sure you document. And if that person refuses, you need to document why or, the information as it relates to the medication administration. And after you have administered all of your medications, you want to monitor the therapeutic benefits. You want to know if the medication that you are giving is therapeutic. If the medication is working or if it's not working, you want to present that information to the provider.